Stiff shoulder is a very common problem that you face in your clinical practice day by day. It is called as an adhesive capsulitis or frozen shoulder. It is called by different names. So today we will be focusing on what is stiff shoulder, what we can do to prevent stiff shoulder, how we want to treat it, and when you want to intervene, when you want to do something to treat this stiff shoulder. So can you tell me what are the types of stiff shoulder or adhesive capsulitis or frozen shoulder? So it is either primary or secondary. Primary it is idiopathic, that is without any reason, or secondary. So primary will be idiopathic, that is without any reason, and secondary is something secondary. So because of any trauma, because of any surgery, because of any event, the shoulder has become stiff. So for idiopathic, it is more commonly the cause is not known, but you need to take care of two things. It can be more associated with some metabolic syndromes. And what are those metabolic syndromes?
Diabetes.
So diabetes is one. So you have a high chance of stiff shoulder in diabetes mellitus, hypothyroidism, and one more metabolic condition. So hypertriglyceridemia or hypercholesterolemia.
Yes.
So if you have these kind of a three is cholesterol, thyroid and sugar. So these three can cause a high risk, or they have a high chances of having a frozen shoulder or a stiff shoulder, or these patients are more prone to develop frozen shoulder. Now this idiopathic type is usually defined, they are classically said to be a self-limiting sin. So if they come and they will go after a course of about 6 to 8, 10 months. So these will start with an inflammatory episode, then they will be stabilized, and then they will be slowly reducing. So, but this duration is not fixed. Some patients it will 2 to 3 months, some patients will be 6 to 8 months, and some patients it will be 10 to 12 months. So these are the things, disorders you must rule out if you have a shoulder which is stiff without any cause. The secondary syndromes or the secondary stiff shoulder is usually secondary to either trauma. So what are the most common causes in trauma?
Accidents.
So you can have either a soft tissue injury or a bony injury. So a soft tissue injury like a rotator cuff tendon tear can cause a secondary stiff shoulder, or you can have a fracture which can cause a secondary stiff shoulder, or you have a surgery done on a particular patient for any reason, and that cause post-operative. So these are the secondary causes of the stiff shoulder. So these are the traumatic causes of the stiff shoulder. Now these kind of a secondary traumatic are little bit behaving differently from this. So they may not follow the classical improving phase that usually we see in the idiopathic form. So they may have a chronically persisting sort of a stiffness, something like that, because of the trauma, because of the accident per se. So if you get a patient with stiff shoulder or adhesive capsulitis, what is the initial things that you want to do? Always take an X-ray. A basic baseline X-ray will give you a lot of information, and also it will rule out important pathology. So these stiff shoulder, sometimes you may have a locked posterior dislocation, which is very commonly labeled as a stiff shoulder. It's very common. So you may have a patient who has a locked posterior dislocation. The second very close differential is a arthritic shoulder. This may also be very closely mimicking a stiff or frozen shoulder. And third, which you can identify on the X-ray, is a calcific tendinitis. That's why in today's case I was asking for the X-ray. So if you have a calcific tendinitis, it may also behave like a stiff shoulder, arthritic shoulder, and locked posterior dislocation. These are three things which you can identify on the X-ray. So an X-ray is a must. So once you get an X-ray is normal, the patient has got restricted range of motion, you can safely start them on physiotherapy, exercises, pain medications, and some sort of rehab, some sort of local modalities. Usually they will feel good. So 80 to 90% of the patients who are with primary frozen shoulder without any reason, idiopathic type, usually will resolve with conservative management. So these will be patients who you need to start on pain medications, anti-inflammatories, physiotherapy, and modalities. But occasionally some of these may not respond to to conservative treatment. We'll be coming on to that, what needs to be done. But always when you get a patient, because these three are the factors which may increase the chances. So always get a blood sugar, HbA1c, thyroid profile and cholesterol profile. So you always get this blood investigation done to rule out these things. And if these are elevated, try to treat the primary pathology as well. Because if you treat them, the recovery will be faster. So blood investigations for that. Now when you will get an MRI, in this patient who is having a stiff shoulder, who is presenting to you, when you should get an MRI scan?
So if in an X-ray,
Does not
the
diagnose
humeral
properly.
head is superiorly migrated.
Okay, so then we are suspecting a rotator cuff. We are suspecting that X-ray is normal
Okay.
and the patient is having stiff shoulder. When you will get an MRI?
A weakness in the shoulder.
Weakness.
If
So how will you differentiate a rotator cuff pathology with a stiff shoulder?
So
Passive range of movement.
Exactly. So in rotator cuff pathology, active range of motion will not be there, but passive range of motion will be there. But in adhesive capsulitis,
Mostly in the
most
posterior,
active and
compartment,
passive
yes.
both will be gone. So if the patient wants to do this, he will not be able to do this in both.
Yes.
But if you assist him, he will be able to do that. So in active and passively differentiate, you can do active and passive, you can differentiate that. The important thing is if you are suspecting something else, like in post-traumatic scenario, or you are suspecting something which is more than a stiff shoulder or a frozen shoulder, then ideally you should prescribe an MRI, or in a patient who is not responding to the conservative management. And if you get an MRI, what are the classical features that you see on the MRI in a patient with a stiff shoulder or adhesive capsulitis? MRI features.
Axillary pouch obliteration.
Exactly. So one is axillary pouch operation, but before that you can see something. You will see hyperintensity in the rotator interval area. Initially it will be, you will see a hyperintensity, and there after that you will see fibrosis. So rotator interval, two things you need to look after. First is the rotator interval and second is the axillary pouch. So in the rotator interval tissue you will see a lot of edema, a lot of inflammation in acute inflammatory stage, and later on you will see obliteration of the rotator interval and of the axillary pouch both. So you will see a slit-like axillary pouch. So if you see the MRI here, normally you have a axillary pouch which is like this. Now in this the axillary pouch will be obliterated. There will be very small streak-like of thing which you will see on the MRI scan. Now those patients who are not responding to conservative treatment and physiotherapy, what are the options you can advise them? What are the options which are available with you? There will be only 10% patients. 90% of patients will respond with the rehab. So 10% patients not responding to conservative treatment, what are the options?
Manipulation under
Manipulation.
Oh, that is very old, or if very old-fashioned surgeons do with the any manipulation under GA. That is one. Anything else?
Capsular release.
हाँ, so capsule release उसके पहले in between them. So injections.
Intra-articular.
So intra-articular injections. So what are the two types of injections which are prevalent nowadays?
Steroid.
One is steroid. Yes. And then there is a therapy which is called as hydrodilation. What is hydrodilation?
NS.
We inject normal saline into the joint.
Yes. So what you want to do here is you increase the pressure inside the joint and try to break the adhesions. This is called as hydrodilation. This is also a form of injections. You inject normal saline, but you inject a lot of saline under high pressure. So you break the adhesions. You try to break those adhesions with the use of this hydrodilation.
So
And steroid will actually
What is MUGA?
MUG is manipulation under general anesthesia. So what the patient is anesthetized, and then you manipulate the arm to regain the motion. So you break the adhesions
Yes,
basically
yes,
forcibly.
for breaking the adhesion.
Forcibly. So these are the three things which are, and then the final treatment.
Hydrodilation works. The hydrodilation works.
Hydrodilation is a very recent concept. There are some studies which shows that it works nicely. I don't have a personal experience. I don't do it, but there are some studies which say that it works. Anyway, we'll come to the next. Is the arthroscopy, and in arthroscopy you do hydrodilation
We have
automatically. So because you inject, you insert the trocar and then you push the fluid under pressure. So you are doing hydrodilation automatically. So in arthroscopy you are doing hydrodilation as well, And in arthroscopy, you do a procedure which is called as a capsular release. So what you do is a 360-degree capsular release. So if this is your glenoid, you want to release the glenoid circumferentially. All the sides, all the 360 degrees, you will release the glenoid. All the 360 degrees. Now, this is a difficult surgery in a very, very tight joint. So can you tell me a technique to do this without problems? If you have a very, very tight joint and supposedly you are not able to insert the trocar of the arthroscope into the joint, what will you do? If you are able to insert the trocar, mostly you will be able to do release. But if you are not able to do the first step, that is you are not able to insert the trocar, what will you do?
Injecting fluid in the joint.
That is one option, yes. Then, after that also you are not able to do it. You can do a gentle manipulation, then try again. That is one. Any other option? Third. There is a technique which is described as the extra articular arthrolysis. This was described by Dr. Laurent Lafos. That basically technique, what we do is, this is your shoulder joint and this is your rotator cuff. So what you do is you go into the subacromial space. You can go into the subacromial space as easy in a normal patient as easy in the stiff shoulder. Subacromial space is free, there are no additions there. You go into the subacromial space, do a subacromial mastectomy, then through the subacromial space, you go into the rotator interval and do the rotator interval release from the top. And once you are doing the rotator interval release, you will be able to go into the joint and then do your 360-degree release. So this is, in a very stiff shoulder, you can do this technique of extra articular arthrolysis. So you don't have any complications with the trocar insert. Otherwise, if you insert the trocar forcefully, you may damage the cartilage. So this is the extra articular technique of arthrolysis. This you do in very stiff shoulder, which you are not able to push your joint inside. Okay? Any questions? Okay.
सर एंटी जब आर्थराइसिस करते हैं हमारे जितने भी स्ट्रक्चर्स हैं सबस्कैपुलर वहीं पर हैं तो ये
So you have to release the capsule. You don't have to do the subscap. You need to, when you are doing the arthrolysis, you need to see the mobility of the subscap. So once you do it, the subscap should be mobile. So you should be able to do internal and external rotation of the shoulder after you do it. So that is what you need to check.
only capsule
Capsule, and that is 360 degree recommended.
and GHL SGHL
Everything.
they will
This is
discuss-
MGHL, SGHL is capsular technique.
capsular thing.
So you release everything,
They will-
and you release it close to the glenoid. So you release it from here to here to here, and then from the back here to here. So anterior and posterior should meet at the inferior portion. That is a 360 degree. Once you do this, you will have a drive-through sign which is positive, and then the shoulder will be pretty mobile.
सबस्कैप बचा
Subscap you don't have to do. Subscap you need to see the excursion. It should be free once you do the release. Okay? Thank you.